All right, folks, let's get started. More people have joined and we got lots to share with you today. My name is Alex Harper. I'm an occupational therapist and a postdoc fellow in the Department of Physical Medicine and Rehab, and we really appreciate your interest and your time today. So thank you for joining this webinar hosted by MISHAR's Behavioral Research and Innovation Support Program, also known as BRISP, in partnership with the eHealth and Artificial Intelligence team here at Michigan, also known as eHale. So today's webinar will last roughly an hour and a half. First, we're going to hear from Dr. Nirali Shah, and then we'll give you about 10 minutes for specific questions to Dr. Shah. Then I will introduce to you Dr. Veronica Rosas, and we'll hear her presentation. Then we'll do another 10 minutes of questions specific to Dr. Perez Rosas. And then the remainder of our time, we'll kind of open it up for open Q&A for whatever questions you have for either of our speakers broadly. So just so you know, we will make captions available to you, and we are going to be recording this webinar. Figure out captions. So let me introduce to you our first speaker. Dr. Nirali Shah is a physical therapist by background and currently a postdoc research fellow in the Department of Physical Medicine and Rehabilitation here at the University of Michigan. She completed her PhD in Rehabilitation Sciences at Boston University in 2023. Dr. Shah's research interests are in developing and investigating digital health tools for management of chronic pain conditions. So we look forward to hearing from Dr. Shah. She'll be sharing her screen here momentarily.
Sorry, everyone, but again, hi, everyone. Thank you for the introductions, Alex. Let me just go ahead and make sure I'm sharing the right screen this time, so that we're all on the same page. Okay, hopefully you're now seeing the slideshow, which I think you are. Okay, so good morning, everyone, and happy Thursday. Today, I'll be talking about my ongoing work here at U of M, which is using NLP, or natural language processing, in a self-management intervention for people with scleroderma. I will be discussing the project more conceptually because I'm only stepping into the world of AI. And there has certainly been a learning curve for me. And so I'll discuss some lessons learned at the end of my project. So I'll start by giving an overview of scleroderma. Scleroderma, or systemic sclerosis, is a complex rheumatic condition which is characterized by highly variable symptoms. It can range from mild to aggressive, life-threatening multi-system involvement. There is currently no cure for scleroderma, and self-management interventions are recommended. There's also strong evidence from systematic reviews that suggest using mobile health strategies and providing additional support by health coaching. Therefore, we developed a self-management intervention called Renew. As you can see on the slide, this intervention was accessible by both website and mobile phone, and it offers education modules on managing the condition and peer health coaching. The peer health coaching is a system where a trained team member with scleroderma guided participants through the modules and helped them set or modify behavioral goals. Now, this was done by 9 one-on-one virtual health coaching over 12 weeks. We conducted a randomized control trial among 173 participants where we compared this intervention with a waitlist control. At the end of 12 weeks, we found that Renew participants experienced clinically meaningful improvements in fatigue, pain interference, depressive symptoms, and resilience with moderate to large effect sizes compared to the waitlist control. As you will also see, we found that there was variability between people in the Renew group. So people with scleroderma who had a short disease duration, which is 0 to 1 years, had more improvement compared to those with a longer disease duration, which is greater than 5 years. Although these results are promising, sustaining such an intervention in the real world is challenging. And this is because trained peer health coaches are scarce and ongoing support is expensive. And this is where AI comes in. The idea is to supplement the peer mentor health coaching in a way that eventually scales Renew, reduces burden on peer health coaches, and also reduces the resources used towards the intervention. By using AI to support Renew, our goal is to improve accessibility, availability of the intervention, engagement, costs, while providing an intervention that is individualized and also may help empower people with scleroderma. However, as a novice in the field of AI, we took some time to decide what type of AI would be most appropriate for us. We considered reinforcement learning, natural language processing, NLP, and decision support systems. Reinforcement learning uses a trial and error approach where an AI agent learns to make decisions by receiving feedback from the environment. Thus, it optimizes its actions based on rewards or penalties to improve over time. However, it lacks the conversational and empathetic qualities necessary for effective health coaching. We also consider decision support systems that relies on predefined rules, algorithms, and large data models to analyze information and provide data recommended treatment plans. But again, it may not foster the interactive reflective dialogue that health coaching requires. You know where I'm going with this. NLP enables dynamic and human-like conversations, allowing for real-time personalized interactions that can emulate the supportive and educational environment of traditional health coaching. NLP includes both non-generative and generative machine learning techniques to facilitate meaningful conversations between human language and computer systems. Non-generative NLP techniques include text categorization, sentiment analysis, language translation, information retrieval, and development of rule-based conversational agents or chatbots. Conversely, generative NLP allows for human-like responses, leveraging recently developed advanced technologies such as the GPT series. Now, these models utilize deep learning algorithms to predict subsequent words in a sentence, and it's based on a vast amounts of training data from diverse sources, ensuring that the generated responses are relevant and contextually appropriate. Now that we've decided that we want to use NLP, specifically generative NLP, we explored the various options available to us. We decided that we wanted to use an off-the-shelf GPT. And so we considered using OpenAI's ChatGPT series and the various AI tools available at U of M. After understanding the course of various options, we decided that we will use UM GPT Toolkit to integrate an in-house GPT series into the Renew mobile app. This way, the data could live on the UM servers and we would have complete control over the AI environment. The goal is to emulate health coaching environment using a chat functionality within the Renew app. We want the AI health coach to provide scleroderma-related education and health coaching to set or modify behavioral goals. The long-term goal is for the AI health coach or the chat functionality to supplement human peer health coaches and not necessarily replace them. So to develop this AI-based health coaching behavioral intervention, we will be using the NIH stage model for behavioral intervention development. As you can see here between stage 1 and stage 2 and the double-ended arrows, the model recommends an iterative process where there is a continuous refinement of the intervention as we move from efficacy to effectiveness trials. We will conduct this development in multiple phases. In phase 1, our study, we will integrate a generalized GPT-4o model into the Renew app. And this will be an initial proof of concept to just explore how people with scleroderma utilize the chat feature for health coaching. We will develop customized text responses for this. These text prompts, I apologize. It's a Thursday. These text prompts will undergo multiple refinements. And initially, a researcher would review video recordings of the human health coaching and develop an initial set of text prompts. We will generate 2 sets of AI-generated transcripts, one addressing a physical barrier and the other addressing a mental barrier to goal achievements. These transcripts will be shared by participants of the original Renew trial, specifically 30 people and 3 peer mentors. We will get feedback on the clarity, helpfulness, emotional support, and overall satisfaction. We will also get feedback through focus groups. We will then get their feedback regarding the chat interface to identify any usability issues and areas of improvement, particularly because people with scleroderma often have limited hand dexterity. These customized text prompts and the generalized GPT-4 will be integrated into the Renew app using API. In phase 2 of the study, we will have 20 people of the original Renew trial use the chat functionality over 4 weeks. They will be instructed to use the app at least once a day for 4 weeks. We will collect engagement metrics and clinical outcomes before and after the 4-week intervention. At the end of 4 weeks, we will conduct qualitative interviews to learn about participants' experiences in using the AI health coach. Note that the NLP model here is just a generalized model, meaning the health coaching is not individualized and the education is generic. Now, you may remember that the original Renew trial showed that the duration of systemic sclerosis, so the early, which is 0 to 1 years, versus late, greater than 5 years. So people with a shorter duration of systemic sclerosis experience greater improvement, and this causes for fatigue, compared to those with duration of greater than 5 years. Now, these findings were further supported by qualitative feedback, which indicated distinct preferences in health education content, coaching frequency, and the pace of the intervention. So those with the shorter disease duration, which is less than 5 years, preferred less frequent health coaching, more generalized health information, and a slower paced intervention. While those with a longer disease duration valued the frequent interactions, but they desired more detailed symptom-specific educational content. And therefore, in the next phase of the intervention, we wanted to refine the AI-supported health coaching in a way that it becomes more personalized for people with scleroderma. In the proposed refinement, we will use transfer learning techniques to refine the existing GPT-4o model within the Renew app. We will collaborate with machine learning experts at the university to help us with this step. We will use information related to scleroderma disease severity, duration, self-reported symptoms, patient preferences from phase 2, which is the pilot trial, and general recommendations for non-pharmacological treatments to refine the model. Our goal is to provide a more personalized health coaching to people with scleroderma. Similar to phase 2, we will conduct a pilot study with 30 people with scleroderma, investigating use, engagement, clinical outcomes, and of course, qualitative feedback at the end of the 4-week intervention period. This time, the model is more refined and incorporates preferences and feedback that we learned from phase 2. This is an overview of the interventions. In the original Renew intervention, we had education and virtual health coaching with no AI component. In the ongoing study, we are integrating a generalized GPT-4, this should be a GPT-4o model, without any sort of training, which will give generic health advice and behavioral health coaching. And in the refined model, we will train the GPT-4 model on various aspects related to disease severity, self-reported symptoms, and non-pharmacological treatment recommendations for personalized health coaching experience. Now, I have mentioned this several times. I am someone who's new in the field of AI. And while developing these text prompts, we definitely faced some challenges. The first one is monitoring of the conversations. For the Renew study, we have decided to use retrospective manual screening of chat conversations, but we haven't figured out how do we ensure filtering of inappropriate or false information in real time. So the monitoring will only be retrospective. Repeatability and reproducibility. How do we ensure consistency in interactions? For example, when we interact with the generalized GPT-4o model as a patient or a participant, we find that even if 2 people may have the same barrier, the conversation and the recommendation for the behavioral goals may vary. At this moment, there is a lack of predictability. But as we continue with our project, we will understand the impact of this variability more. Hallucinations. Many of you may already know this, but the GPT-4 or GPT series in general tends to lie about references or resources. We have also found that the model does not always follow instructions. For example, despite specific instructions, it would only focus on a few behavioral health goals from the list of goals that we provided it. So for example, it would rather focus on physical activity or nutritional goals and focus less on pacing activities or practice the positive. Finally, a huge bias for the model is that it mostly tends to agree with the user instead of challenge them. And as you may know, in behavioral interventions and health coaching, we need tactful challenging of existing views to foster improvement in behavior. So lessons learned is we first identified a need for our intervention, and we determined the expected outcome, and we developed the initial prompts, and we had to make comprehensive but specific prompts. So for example, something as small as limiting responses to 100 words, or use fourth grade language level for our participants, or also advising. So the language model tends to advise more rather than promote reflective thinking. And we had to definitely modify and refine our prompts so that it would emulate the reflective thinking that occurs in human health coaching. And most importantly, the refinement still continues to this day. So the process of testing for reliability and refining is ongoing. Overall, from start to finish, these are the lessons that we have learned as a clinical researcher who's a novice in the field of AI. We first determined the need for a more tailored treatment. We determined the expected outcome, which is higher personalization and hopefully higher engagement that comes with an AI health coaching that's available in your pocket. Our conceptual or behavioral change model guiding the intervention is that we want the AI intervention to be non-inferior to the traditional Renew intervention. And we're hoping that with increased engagement and timely treatment available to them, they may be able to change their behavior more effectively. We developed a proof of concept, and we tested this within our team with the researcher and the rest of the team, the art fellows and the peer mentors involved in our team. We refined that based on feedback, and the pilot study would test that within the targeted population. Lessons learned from the pilot study will be used to refine the model even further, and this process continues on as we are able to develop an AI health coach that is satisfactory to then move on to efficacy and effectiveness trials. So during this time, some lessons learned were the importance of building the right team. Finding the right people for an interdisciplinary work in an emerging field like ours is challenging, but resources like eHealth and Mishar have been incredibly helpful. It can also take time to find committed team members. Many may be enthusiastic about the topic, but may lack the time or the availability to fully engage. So for that, I would like to offer some tips. The first is to get clear on your specific goals. Be explicit about what you need and the type of research you aim to conduct. Attend workshops like those offered by eHealth and Mishar to connect with peers and increase your visibility. Once you have a clear ask, reach out to AI experts, especially those with healthcare experience, and expect the team building process to take twice as long as anticipated. Finally, be patient and flexible because this is something I'm still learning. And given how new this area is, there is a steep learning curve, and it will just take time. The second thing I've had to learn is how much technical knowledge do I need to have as a non-AI clinical researcher? As a clinical researcher entering the world of AI, you don't need to be an expert in programming or AI algorithms, but having a foundational understanding of AI concepts and how they relate to your field may be highly beneficial. You may want to improve your understanding of basic AI concepts, meaning the different types of AI and how these techniques are available or applied in healthcare. Data handling. So for example, in Renew, it is beneficial to kind of know the data back end of how the Renew mobile app is stored on the servers, how it is structured, what is an API, and how does the integration look like. The tools required for the project, so the need for a Mac or a virtual machine to make the app available on both iOS and Android devices. Learn the language and keywords required for collaborating with an interdisciplinary team. and that mostly comes with exposure. Finally, what type of AI or GPT series? Again, we have learned that we need to define the problem clearly, focus on what we want the AI to do, and again, find the specific expected outcome that we want, and then match the AI type to project goals. And also another important thing, which is not really related to science, but some logistic things that we've had to learn was, of course, consider the access to teams and collaborations we may have, what the IRB prefers. So that would really differ from the institutional IRB, what your grant funders might prefer, and also the available funds, scope, and timeline of the project. And yeah, that's about it. Oh, I'm perfectly on time. Look at that. That's great.
Thank you so much, Dr. Shah. Folks, you are welcome to pose questions using the Q&A feature, and you are also welcome to raise your hand and I will allow you to come off mute to ask your questions. Give folks a minute to see if anything pops up, but if not, I do have a question for you. Well, while people are thinking about their questions, Dr. Shah, I've got a question for you. You said that you're novice to this and you're new to the University of Michigan, so I'm wondering if it would be helpful for the audience to hear some of the resources you explored here at Michigan as you started looking into AI and finding partners or mentors or something like that. We'd love to have some conversation about that.
Yeah, thank you for the question. I think University of Michigan is really incredible because it has so many resources. So for someone like me who's still starting out, it is great. I think I found eHail very beneficial. Just a symposium last week or just meeting different people through eHail. The Mishar UMSI, so the School of Information, they have these machine learning experts who give 20 hours of consultation for free. So that is something that's incredibly helpful as well. And they'll also review your grant and make sure that you're technically sound in your grant. And I think eHealth also offers that. So I personally have found these two resources most helpful.
Great, thank you. All right, we've got a couple of questions popping in. So let's start with Henrique. Dr. Florbosch says, thank you for a great presentation. Do you envision applying for an external grant for this project? And if so, where might you look?
Yes, thank you for the question. We have applied for an external grant and we're hoping to hear back in December. So we applied for the Rheumatology Research Foundation and hope we once we hear back in December, we're also hoping to apply for an NIH K99 and RO series. We are currently focusing on more healthcare related grants. We haven't focused on more. That's a fun thing about integrating two fields, right? You can think about different grant mechanisms, but we're currently focused on more rheumatology focused mechanisms, and we might expand to more AI-based granting mechanisms, yes.
Great, thank you. Next question is from Mary Janovic asking, how do you explain to participants the possibility that the AI can hallucinate or give incorrect information? How have you handled that so far?
That's a great question. So that is something that we've definitely thought about how do we, so we cannot really, we have to enhance trust in participants for the use and application of AI and also reduce misinformation or fear that may be out there. We have in our informed consent told the participants and explained the scope of what the AI can do and what we're training it to do. And we also explained to them the drawbacks of using AI, which includes hallucination, and they always have access to a researcher on call. So if they're not sure about any information that's given to them, they are always encouraged to reach out to the professional team for further advice.
Great. Thank you, Dr. Shah. We've got one more question in the chat box saying, for participants who wanted more personalized information, did you create personalized chat responses for those individuals, or did you have them tell the GPT like their individual symptoms so that it could then be tailored to them by the system?
That is encouraged at the participant level. So at the system level, we're not making those changes. At the system level, we're training the GPT to kind of give generic responses based on the symptom severity, but for the individual variability that each participant face, we have them put in their information. So that's at the participant level.
Great. Thank you for that answer. Then we have one other question here, and it's a question that I'll pose to both you, Nurali, and to Dr. Perez Rosas later, but I'll be interested in this last minute or two before we switch presentations to hear your thoughts on the biggest barrier or barriers that you've experienced to University of Michigan investigators interested in using AI for future studies. You are muted right now.
Sorry about that. This has definitely personally been a challenge because there's a lot of focus of using AI for precision medicine and just internal medicine and those kind of fields. But for behavioral science, there are few experts. And while people may be definitely interested, and rightly so, in advancing their ML models, I think applications for a small study like ours, while people may be, like I said, interested, but having the time and availability to commit to something like this has been a challenge. But fortunately, people still do want to help you with whatever limited time that you do have. So I think just like being independent and kind of driven in your focus and trying to get be very specific about your ask, and because people don't really have the time to just this is a niche area, so it is going to be a little difficult to kind of get the right committed support that you want, but having a specific ask, and people definitely do want to help you if you're clear about your goals. You're muted, Alex.
Thank you so much, Dr. Shah. We really appreciate hearing your insights. Thank you so much for the presentation.
Thank you.
Dr. Perez Rosas, if you are ready to start sharing your screen, I will do your introduction. So now we're going to hear from Dr. Veronica Perez Rosas. Dr. Perez Rosas is an assistant professor at Texas State University. She received her PhD in computer science and engineering from the University of North Texas in 2014 and was, up until August of 2024, an assistant research scientist here at the University of Michigan. Her research interests include natural language processing, affect recognition, and multimodal processing of human behavior. And her current work focuses on user-centric applications for the healthcare domain. So Dr. Perez Rosas, we welcome you, and we are seeing your slides just fine.
Hi, everyone. Thank you, Alex, for the introduction. I'm very happy to talk to you today and share the work we have been doing on developing NLP-based feedback for enhanced counselor training, which in short translates to using AI to enhance counseling training. During this talk, we are going to describe first a background on counseling and current NLP work. And also I'm going to offer you a sort of different perspective with respect to what Nirali showed. And this is building in-house NLP systems for counseling training. So I'm going to walk you through some of the steps that are required to build such applications from scratch. So I'm going to talk about two different applications we have done in our lab. One is building response suggestion systems that will provide, excuse me, it will provide given that counselors are training to talk to their patient, it will provide response suggestions and also response scoring. And then we'll talk a bit on what are the challenges associated to this type of work and what we are doing currently to sort of improving this feedback. First, as you know, we need more mental health care providers. And this one of the reasons is that we are experiencing a growing counseling shortage. And this obeys to many, many reasons. Among them, the effects of COVID pandemic and also the opioid crisis and other sort of um, societal issues. And that has been an enormous demand for mental health services. Just to provide a recent statistic from the healthcare domain, where they have said there are 350 individuals for each mental health care provider. And this is worrisome because all the people who is actually in need of healthcare is not receiving appropriate care. And one of the reasons among many is that new counselor training is costly. It needs expert supervision and is also a laborious process. What I mean with this is that traditional counselor training usually undergoes three main stages. First, novice counselors do conversational practice, and this can happen with a peer, or perhaps it happened with a standardized patient. And then they go to an evaluation phase, where they do either self-report, client retrospective, or peer evaluation. And that only comes after they have talked to or they have done the conversational practice. And usually the feedback for these interactions comes really after the fact that the conversation have happened, and it's very time consuming and is neither immediate nor frequent. And usually this requires that experts are recording the conversation and then watching it and then coding what is happening in it, and they are being able to provide feedback. So for these particular scenarios, we see that NLP can assist for several tasks. And one important application we are concerned about is how can we use AI to generate feedback for such interactions. So one application we envision is to produce language suggestions. For instance, in chat-based systems, if the counselor is talking to their patient, they could receive suggestions on what to say next. And one of our hopes is that this type of system will sort of help first during the learning process, and then let's say they are being used by counselors in practice, it could also reduce the burden of thinking what to say next by receiving some hints about it. And other scenarios where these technologies could be very helpful is for non-face-to-face conversations, for instance, video or chat-based counseling. And the idea is that we will be able to provide accurate and ongoing evaluation and feedback at the scale. So rather than having a set of experts reviewing each of these recordings, we'll have a system that provides feedback after the fact. And then when we do it also in real time, we could provide counselors with real-time suggestions. An important part of it is when counselors are learning how to respond to their clients, they usually like to see examples. This could sometimes is just a sort of the instructor provides in counseling a scenario and they come up with responses. However, the evaluation of responses is not immediate. So we build the system targeting one conversational skill called reflective listening. This is a conversational strategy used by a counselor to show understanding of their client's feelings and perspective. Usually it turns like the client has said something and then the counselor listens and reflects on what they hear. For instance, I had a hard time trying to quit smoking this week, and the counselors will try to make an educated guess of what is happening. It sounds like quitting smoking has been really challenging to you. We're thinking in terms of these scenarios, how can we provide feedback? So one of the very earlier works we did on our lab is to explore the use of language models in counseling and developing text or context augmentation strategies. For that, all this work was in collaboration with experts. So we talk to counselors and ask them, what are the strategies you use more frequently to show or to generate these reflections? So they highlighted two main strategies. One is that they use previous knowledge to generate reflections. And second, they use rephrasing and synonyms. So we built an NLP-based system that tries to translate these ideas into a running system. So first, when they use previous knowledge to generate reflections, we build a module that identifies reflections from related sessions based on the context. And when they use rephrasing and synonyms, we try to do the same with expansion of synonyms, verbs, and noun expansion. Our system looks, this is the pipeline for our system, and it has three main components. First, starting with the dialogue history, we have utterances from the client and the utterances from both. For the utterance from clients, it goes through a module on expansion of the different words we see, and we identify keywords who are then fed to the generation system. On the side of conversational turns, we first go and identify conversations that potentially have reflections that fit within the context. So we have a knowledge base or a transcription database where we get counseling transcripts and then identify what matches we can find. And then we use a classifier to identify which of them are relevant to the given context. And then this information is also fed to the generator, and we generate a response that now is has a improved context in terms of expanding the speech from the client and expanding also on the database knowledge information. And if you are familiar with it, this method is actually comparable with current retrieval augmented generation systems that rather than using a database, use a large language model to bring additional information for the generation system. We evaluated our system using automatic evaluation for language generation. And in that, we used two main metrics. One is called Rouge, which measures the word overlap between the response that has been generated and the response that was produced by a human. And the second one is called embedding average, which goes at the semantic or meaning level, where we try to see, even if we change words, are we keeping the same meaning within the response? And then we test several variations of our systems, and we compare against a baseline that a very basic language model that just predict the next token based on probabilities. This is the sequence-to-sequence model. And the second is a model that is only fine-tuned or brings closer the model to the language of this counseling conversation. And the second and third are models that actually use incrementally the techniques we explained. One is the retrieval, where we bring information from previous conversation. And the second is the expansion, where we try to expand the kind of wording that exists within the response. If you see in the results, Rouge sort of give us a sense of how well we did on the lexical level, that is the word overlap, and the embedding average within the semantic level. So we see a trade-off between using retrieval and expansion. And in general, we see that our systems are actually doing much better than just simple language models or fine-tuned models, which tell us about how important it is to incorporate the expert feedback to build these systems, not just using off-the-shelf systems. Second, we decided to do a human evaluation to measure whether the reflections we were generating were actually reflections and whether they were of good quality in terms of language. So we measure three aspects. We measure relevance, whether the conversation is in context. For instance, we were talking, let's say the conversation is talking about smoking cessation. the generation is also talking about the smoking cessation and whether it follows the previous turn. And then does it look like a reflection? And this is a very subjective question, but the people who annotate these examples had a background in counseling, so they knew how a reflection looks like. And then we ask about quality, whether it was grammatically correct or fluent. And here on the right, we have the output of our systems. We have in blue the ground truth, and then the sequence-to-sequence model, the fine-tuned model, and then our model augmented with retrieval and context expansion. And in the y-axis, it's that we ask each evaluator to provide a Likert score between 0 and 5, where we ask for relevance, reflection, and quality. So if you see, in general, we did very close. This is our best system, the one in pink, and it's very close to the ground truth, meaning that overall, our users were, or evaluators were prefer our system than prefer system more times than other systems, and then they prefer it very closely as the ground truth. This gives us an idea that our system was actually able to produce reflections were on target and were of quality. Here are some sample outputs of what the system produced. So here we have the context. Let's say within the context, patient has been diagnosed with prediabetes and they are worried how this is going to impact their everyday lives and activities. And then they say that they are worried about the future. And then within the ground truth, the counselor reflects back on, sounds like you want to make some changes to make sure you don't have to go through some things your father went through. And if you see the sequence-to-sequence model output is actually a mismatch because it's not within context, it's not within the conversation, and it does contain a reflection, but it's not within context. So, okay, no mismatch. And then the fine-tuned model brings a bit of within the language of counseling. For instance, you are really concerned about your weight, but doesn't have more inference of what is happening. So the fine-tuned model that uses expansion and also the retrieval says, so you are concerned about your health and where it might go in the future. This example shows that our system was able to infer what is happening given the context. Now, so far, we have shown counseling trainees potential wording suggestions, full-blown response of what a reflection would look like for this particular context. But let's say the counseling trainee has generated a response and they want to know how well they did. This is the task we try to address. So we try to evaluate counselor responses again for reflective listening. So let's look at this example where we have the statement by the client. My mother died of breast cancer, so I know I'm gonna die of it too. There are several potential responses. Here I'm showing 3. For instance, the first one is there are measures you can take to prevent the disease. The second is you believe you will die from breast cancer just like your mom. And the third one is your mother death was devastating. You are worried you might die the same way she did. So for these different responses, if you notice, there are several degrees of reflective listening skills. In the first one, this is actually not a reflection, this is just a statement. The second one is a simple reflection where we reflect back, but we are just restating. And in the third one, there is an inference. So there is a complex reflection. So imagine that you are a student and then you have responded someone within this range of responses and with some counseling skills. So how can you evaluate it? You could categorize. You have not produced a reflection, you have produced a simple reflection or a complex reflection. However, in practice, we found that that did not provide enough information to the counseling trainee in terms of how close they were to improve and get a complex reflection rather than a simple reflection. So we decided to evaluate it in terms of giving a score. So non-reflections, we tried to give a score between 0 and 0.3, and then a simple reflection between 0 and 0.7, and then a complex reflection between 0.7 and 1. How can we do that? We use NLP to design a task where we want to assign a score between 0 and 1 to reflection responses. And what we have for our learning task is that we have the prompt or the situation the counseling trainee is going to receive, and then examples of the different responses that could appear for this particular prompt. So for it, again, in the example we see, we have these 3 different responses with different qualities. The first one not being a reflection, the second one being a simple reflection, the third one being a complex reflection. However, if you think about it, since the scoring providing to the responses is a number, you will have to provide a very wide range of responses. So you exemplify this response is 0.1, this is 0.2, this is 0.7, this is 0.8. This is very costly because you will need to show the system a very large number of responses. And also difficult to get because it will be very complex for a set of annotators to decide this simple reflection should weight 0.45. What we did is to create a set of examples where we had all these type of responses for that given prompt. So we collected the 318 handcrafted prompts and we asked for expert annotation. And then we also did crowdsourcing to get responses that were more close to what a novel and counseling practitioner will do. And then we also have reflections for a data from existing data set that was annotated with reflection. And our data looks like this. We have expert annotations, and this is the prompt, and this is the potential responses. We have responses that were a complex reflection, a simple reflection, and non-reflection. And then from the data set, from the conversational data set, we also have examples where we had a turn by the client and then the response from the counselor and then annotated with the type of reflection. Excuse me. Now, how can you score a reflection? We decided to use a ranking approach, and this has a mathematical and an NLP model, but let's say that the underlying idea is that you have a prompt and then you have responses of different levels of quality. For instance, you have here the a paired response where you have again the prompt and then you have responses with different qualities. In this case, non-reflection and simple reflection, and then non-reflection and complex reflection. And if you see, these responses are actually ranked. So we know the non-reflection and simple reflection should be closer to each other than non-reflections and complex reflection. And that is what our system learns. We use a method called contrastive learning, which learns to rank and contrast these different quality examples. And our system was able to learn this ranking with 90% of recall. That means we were able to replicate the ranking given by humans. And to evaluate whether users, or in this case, students, will be able to use this during their education and also to find it helpful, we did a deployment of our score in education. And our system did a real-time scoring feedback for reflective responses to a learning scenario. So we evaluated paired at class graduate level psychology class at the University of Michigan, and we showed people this rubric where where they get scoring between 0.7 and 1, they were skilled in generating reflections. If they were between 0.3 and 0.7, it was acceptable. And low scores lower than that indicate that they were not consistent yet. So resistance shows again the learning scenario, and then students generate the responses, and then the system shows the scoring for that particular response and a suggested response. The suggested response at this point is generated by a human. So we have a set of learning scenarios and a set of goal responses generated by experts. After users use our system, they respond to a survey where we ask them whether they thought the scores were accurate given what they have written, whether they were too low or too high. Also, their experience using the system, whether it was complicated, whether they understood this rubric score, whether the system was helpful to them. And in most of the cases, they agree that they found the system useful and the scores were reasonable to them. We also ask them for open feedback where we ask them what aspects they found useful about the system. In most of the case, we found very positive response where they say that they value that they were able to write several times and to get different scoring, and it helped them to build confidence and also to improve over time as they got increased the scores. And I think this in general give us a good sense of the system is helpful in educational environments. For our ongoing work, we are thinking we have systems that score and provide suggestions, but what if we want to do coaching where the student has generated a response and we want to provide revisions? This is the scenario on the right where we have a prompt or response by the patient and then a response by the counseling trainee that is actually of low quality because it received a very low score. So we are envisioning a system that is actually rewriting or rewarding the response by the counseling trainee in such a way it keeps the essence of what they were using, some of the keywords, and also improve the quality of the response, and it gets a higher score in terms of reflective listening. And another venue we're looking at is how to suggest strategies for counseling responses. For instance, now is a good time to make a reflection and also emphasize autonomy. The contributions of this work is that we have created AI feedback models that provide suggestions and learn how to score the responses from a counseling trainee. And the strategies that I show are informed by experts, and that is very important. During this webinar, we have been talking about how we need people to get involved from both sides, from the technical side and also the experts. And one important and very reassuring aspect is that our AI systems were preferred over baseline and found to be close to the ground truth responses. And of course, I want to acknowledge the people who have worked in this project over the years. We have been working on this type of systems for more than 6 years now. And we started just by envisioning how a data set of counseling look like, and then progressing towards how can we assist counselors during the practice. Well, that's it. Thank you.
Thank you so much, Dr. Perez Rosas. It's an interesting conversation. Let's see if some questions start popping into the Q&A feature. Folks, please feel free to enter your questions. But I'll get us started just to, I'll hold my question on barriers, but one question I had is about language models and how does the model evolve or change if you are working with a population that has different cultural preferences or different language patterns and things like that? how does that happen? How do you help retrain a model, or how does that evolve? How do you handle that?
Thank you, Alex. That's a great question. Uh, well, I'd like to say that so far the systems I'm presenting are built for English, and they are actually built from conversations of English-speaking counselors and patients. And one of the interests our lab has is that we want to see whether we can, well, for one, translate these systems to other languages. For instance, one language I'm very interested in is Spanish. And then see whether, for instance, there are many applications where only translation could work, right? So you could translate one system, but we know that there are cultural differences in the way people interact. In counseling is very affected by cultural factors. So one initial step we are doing towards that is collecting a counseling data set in Spanish and exploring whether the dynamics of talking patterns and the way exchanges occur are different between, let's say, English and Spanish. And then see what can we learn from there, and we can infuse within the model so it will adapt to other culture.
Great, thank you so much. It's interesting to hear about. Folks, I encourage you to input your questions in the Q&A or raise your hand, and I will let you come off mute to ask your question to Dr. Perez Rosas. Well, I've got another question waiting in the wings. When you were showing, it was really striking to me when you were showing your results of model testing that, you know, there's differences and substantial differences in scores based on relevance and reflection and quality. So there's obvious trade-offs. How do you wrestle with those trade-offs and finding like the right balance? How does your team approach that?
So we, the straightforward answer is that we cannot control that during generation directly, but we can adapt the model so it will have some metrics that, for instance, will enforce some properties of the text. Some of the properties we enforce is that the system produces responses that are readable, that are grammatically correct, that are polite, that are non-toxic or non-negative, that are not confrontative. However, I mean, those are a set of rules, and then the actual response is not as controllable. It will only work within the boundaries we place. But I think that's a good thing because that allows for flexibility of the model and produces responses. And if you observe, we are using in-house built systems. So we use a base model, in this case, let's say an very early version of GPT, but it's not behind the paywall, it's not behind an API access. And that allows us to sort of put guardrails around what is generated rather than just requesting and then not having control over the generation.
Great, thank you. We still welcome your questions, audience. Well, I'll pose to you the same question. Oh, here we go. We got a question popped in saying, I'm super interested in the possibilities of making the system bilingual. Can you speak more about that possibility and what might be involved?
Sure. Well, thanks, Enrique, for the question. So right now we are working actually with the support of eHail. We have received the support for collecting our data set, the one I was mentioning where we collected the conversations about counseling in Spanish. So we are working in collaboration with a faculty, School of Public Health, where they are very interested in analyzing differences and also in conversations between Spanish-speaking counselors and their patients, and also in how can we translate all these systems we have currently for English to Spanish, and hopefully bring the accelerate the process of counseling training for Spanish. So how is that happening? In our very first iteration, we have collected data. We are analyzing whether the conversational patterns or conversational behaviors in English are similar to Spanish, to see whether we can use the tools we have built in English and then translate it into Spanish. Well, when I say translated, it's sort of a not only translation as per se, but also try to see what needs to be adapted. And then some parts of the system will have to be built from scratch, because we have noticed several differences in the way people communicate with each other. For instance, counselors in Spanish tend to be more directive than counselors that are English speaking. And also patients have a different perception and expectations of therapy. So the language they use also changes.
Thank you so much. That makes me think. So I have a rehab background, and I'm curious about and rehab counselors are quite prevalent. How does this handle folks with sort of expressive communication or receptive communication difficulties? Is there any work happening there with folks post-stroke or post-brain injury or something like that?
Yeah, that's a great question. For now, our system works for language that is well formed. However, I believe that it could be adapted for, like different type of languages, the same way it adapts to other culture. For instance, we need actually training examples of that type of interactions, and then see what are the differences and how we can make the model and understand and learn these differences, and then create responses that will have strategies that a counselor will use. But again, it requires first examples of the behavior we want to learn, and second, expert feedback on whether what we are finding using computational methods actually makes sense within practice. I see another question.
Another question's popped up, and I want to be able to open this up to both you and to Dr. Shaw. And so the question is, can the panelists speak more to having participants interacting with these systems, but only reviewing data for safety issues after the fact?
I'll let Veronica go first, because I think she's obviously been here longer than I have.
Okay, so the system I show, where students provide the responses and receive a score, and also a ground truth response, a goal response. So far, I don't think we are ready to show responses that are completely free in terms of having a language model generated without any supervision. So at this point, we are also involving human supervision before actually showing those responses to students. So we have a set of responses that are evaluated and analyzed, and then the system shows from this pool. The score is what is dynamic there. It depends on what they have responded. In our next iterations, we are actually generating rewrites of the responses. And I think it's true that it could be a concern that what is being generated. But again, since we are using in-house built language models or adapting them in-house, that is a great benefit because we can put several guardrails around the output. So we can build systems that will make sure that there is no offensive language, it will follow a particular style, that certain topics are not allowed. This kind of guardrails are important and should be used before we actually show an output to a final user.
For our study as well, in terms of refining the model that we are using a GPT-4 based model and then refining it, we do have metrics, like Veronica suggested, where we're measuring relevance and accuracy of model. However, this is also retrospective. In conversing with other people who are machine learning experts at the university, there were conversations about somehow automating the monitoring as well, but I don't think there is something that's available at the moment for us to use that. And similar to what Veronica said, we are also using guardrails. So because we are a strictly behavioral intervention, if someone would ask a question about medication, and these are high-risk questions which we do not want any sort of advice, we do kind of train through text prompts the model in such a way that it will just say, I am not, there is a language we use for it, but basically we restrict the model from giving any sort of medication or surgical advice and strictly focus on non-risk or low risk advice for behavior. And in terms of like a direct answer to your question, in terms of the monitoring, the answer is we don't know. Like we're doing all these things in order to kind of make sure everything, like, things go according to plan, but in terms of real-time monitoring, we haven't figured that out yet, or at least we haven't. Maybe other experts have.
Are there other questions? Open audience, you're welcome to direct questions to either panelist or to both. While we're waiting for one to pop in, Dr. Perez Rosas, I'd like to pose to you the same question that we posed earlier to Dr. Shah. Since you spent so many years here at UM and you were quite embedded with this work, we're curious to know, what are some of the barriers to UM investigators interested in using AI, and what are some strategies to help overcome them?
Well, I could speak from the technical side because I'm in computer science. So one of the issues is that if we are interested in applications that for social good and applications that would but one of my main concerns sometimes with technology is that replaces humans. And I would like to see systems that are actually enhancing individuals, addressing the burden of, having to think about something, or, we are humans and we are working on several things. So perhaps having wording suggestions, having hints will be helpful. So these kind of companion systems are very appealing to me. But one of the issues as a AI researcher is what is actually helpful in practice. Since I don't have the expertise and I don't interact with patients, and my point, even I have taken, for instance, a class in motivation interviewing. I have done training for evaluation, but still there are many things that are, I don't perceive it the same way. And that is helpful because I worry about other aspects. But at the same time, one of the barriers is that it's a process to have this conversation and understand what will be the needs and what will be the value of building, let's say, a certain type of system that faces the user. And then the other is finding a common ground of what would be an interesting research question for both, for the clinician side and also for computer science. Because if we think about the retrieval system or about the generation system, perhaps it's not as appealing as understanding differences between conversations in English and Spanish, and then see, like from a large quantity of data that these patterns will arise, and then we understand more about it. So that is so valuable to me, but might be, maybe very transparent to you or for an expert. So reconciling these differences is very important.
I really appreciate that feedback. And I think that valuing the multidisciplinary or interdisciplinary perspective is particularly poignant when it comes to AI and clinical health applications. You can hear in both presentations from two very different perspectives how important it is to have a team that can enable you to focus on your strengths, but then apply it for the greater good of amplifying intervention and health information and training of our future clinicians. So that's great to hear. Audience, we still have a few minutes left, so I'd like to open space for more questions. Comments are great as well. Yes, please. Enrique, I'll let you come off mute. You're welcome to make your comment off of mute.
Thank you. I was typing it, but it's always, I'm not a great typer. Thank you very much, everyone, for putting this on. I just wanted to comment on what you said that was so important, really, Alex, and all of you, about valuing multidisciplinarity and understanding the need of the, let's say, other side of the equation. And that really, for me, ties back to one of the main lessons that Nirali said that she learned is, finding the right partner takes twice as long as you think it will take. I would actually say it takes twice as long as you think it will take, because it is really tricky if you come from very different backgrounds to find this space that is of mutual interest in terms of the impact you can have, but also in terms of one's career goals, especially for young faculty members starting out in careers. You do all want to get tenure, and you all need that, through your own journals. This is not quite a field that is interdisciplinary by nature. So it really takes the very domain-specific expertise of everybody, and then finding that right middle. So I'm very happy to see that in both your cases, you are actually figuring that out.
Thank you so much, Enrique. I think that's a really poignant reflection. Obviously, that's something that you've experienced leading eHale, and we can all speak to in our own worlds. So thank you for the contribution. Any additional questions, comments that folks would like to pose in our final 7-ish minutes? Great question from the audience. So Dr. Perez-Rosas or Dr. Shaw, you're welcome to answer. You can both answer. Where should folks look for to find funding for this work? Is NIH putting out calls? Dr. Shaw mentioned she's going specific to the Rheumatology Research Foundation. Talk to us a little bit about how you fund your work. And let's start with Dr. Perez-Rosas, and then Dr. Shaw will go to you.
Sure. Our work has, well, at the very beginning, I have to say that most of our work was funded internally through MIDAS and Precision Health. And that was very helpful because that helped us to create our pilot data and to create some of the data and findings needed to actually apply for a larger proposal. So we have also applied to NSF. Since Well, my area of expertise is more on computer science. So NSF is our main place to apply for funding. We have gotten for this particular project an Smart and Connected Health grant. And I think there is also interest from companies where they want to see how AI is impacting health, and also in terms of, in my case, for instance, in dialogue generation systems that face or enhance interactions between patients and clinicians. There is, well, there is also, there are also foundations, and I haven't applied for this particular type of work, but I think they also are interested in the in NLP applications that are for social good. For instance, having systems that could train clinicians more effectively for individuals from countries where not enough resources is one of the one of the ongoing health efforts of many foundations who want equity and justice for health.
Great, thank you. Dr. Shah, do you have anything to add?
Yeah, I would like to say, so like I said earlier, I am focusing currently on like the rheumatology route, but digital health also has funding mechanisms, which may be AI based. And of course, then you have the NIH ROO. I'll be applying to the K99 ROO. And also another resource is that Dr. Mihalcia is actually hosting a talk on October 4 about finding the right grant opportunities. And I can put the link to register here. So Alex, I can just send that link to you, but I know that Dr. Rhoda Mihalcia is hosting an event where she talks about this.
Great, I put that link. Everyone should be able to see that in the chat box. It's the registration form for that talk. We have a few remaining minutes, so I'd like to maintain space yet for additional comments, questions, thoughts about AI in clinical health applications. Audience, you're welcome to raise your hand or come off mute. I'll bring you off of mute for that. Right, I think we have pretty much exhausted questions. Folks, if you do have other information you'd like access to, feel free to reach out. We'll get you connected with Dr. Perez Rosas or Dr. Shah, however that would be helpful. We really thank you for your time and your attention, your thoughtful questions and comments for our presenters today. You heard two very different projects that involve AI, one to augment clinical intervention and one to enhance training of clinicians, but they both very clearly are seeking to improve care delivery. So that is something that ties us all together. I personally found the talks interesting, and your questions really helped spur some critical thinking about applications to my own work as well. So to that end, you will receive a survey at the end of today's session. Please do fill it out. We use your feedback to inform future webinars and other learning opportunities. It's really our best way to understand how to meet your needs. And we are genuinely interested in what you think would be most meaningful to you and to your busy days. We know you're all extremely busy. So thank you again for your time. Please fill out your survey and let us know if you have any questions or concerns afterwards. Thank you so much, everyone. Thank you again to our panelists. We really appreciate it.
Thank you, everyone.